Hey everyone and welcome. Today, we're going to pull back the curtain on a procedure that, let's be honest, many of us are familiar with, but very few know the incredible details behind. We're going to explore the hidden art and the science of what it takes to get a technically perfect mammogram.
Really, it all boils down to this one question. It seems simple, right? But the answer is actually found in a ton of tiny, absolutely crucial details that can literally make a life-saving difference. So we're going to dive in and see exactly what those details look like from a radiologist's point of view.
All right, so here's our game plan. We'll kick things off with the basics, the two standard views, and then we'll break down exactly what makes a perfect image for each one. After that, we'll look at some special cases, learn how to spot common flaws, and then finally, we'll tie it all together to see why all this precision is so important.
Okay, so every single screening mammogram starts with two foundational images. These are the absolute building blocks that every diagnosis is built on. So let's get to know them.
First up, you've got the craniocaudal view, but pretty much everyone just calls it the CC view. You can think of it as a bird's eye view, looking straight down. The machine takes the picture from top to bottom, which gives a great look at the inner part of the breast. That's the tissue closest to the center of your chest. And then there's its crucial partner, the medial lateral oblique, or MLO view. This is the big one. It's a single, angled side view image, and it is specifically designed to capture the most breast tissue possible in one shot, especially that area up towards the armpit. It's the most comprehensive picture they take.
So now that we've met the two main players, let's get into the nitty-gritty. We're going to start with the MLO and break down the specific quality markers that radiologists are looking for to say, yep, that's a great image.
This is basically the radiologist's secret checklist, right? It's a 4-point inspection. They're making sure the nipple is clearly seen in profile, that the pectoral muscle is visible all the way down to the level of the nipple, that the muscle has a nice relaxed shape, and that the fold of skin underneath the breast is open and not wrinkled up. Each step is just a way to confirm they're seeing everything they need to see.
And this right here, this is a perfect example of one of those key markers, the shape of the pec muscle. When a patient is relaxed and positioned correctly, that muscle should have this nice, gentle, convex curve. If someone is tense, that muscle can bunch up and actually hide tissue, so seeing that relaxed shape is a huge sign of good technique.
All right, get ready for a term you are not going to forget. The technologist's goal is to pull the breast up and out to get that perfect convex muscle shape. When that doesn't happen, you can get a flaw that radiologists literally call a camel nose. You see how the breast sags and the muscle border becomes concave? It's this super obvious visual cue that the positioning wasn't quite right.
All right, time to switch gears and look at our second standard view, the CC. That top-down shot has its own very specific set of rules for what makes it perfect. So for this one, the make-or-break quality check is a measurement called the Posterior Nipple Line, or PNL. It's basically a line drawn from the nipple straight back to the muscle on the image. Radiologists measure this on both the MLO and the CC views, and here's the rule. The measurement on the CC view has to be within 1 centimeter of the MLO view. It's a brilliant way to double-check that they've gotten enough tissue from front to back. And this is where things get a little funny, but for a really, really serious reason. The nipple absolutely has to be pointing straight ahead. Why? Well, because if it's pointing off to the side, it can totally distort how the tissue behind it looks. It could hide something, or even worse, create a shadow that looks like a problem when there isn't one. It's a non-negotiable point of quality. But, what happens when those two standard shots just aren't cutting it? What if they don't tell the whole story? Well, that's when radiologists call in the specialists, the special views. Each one is designed to solve a very specific problem.
So let's try this out. A radiologist spots some really tiny, maybe suspicious calcifications, and they need to get a much closer look. What's the call? What view do they order?
The answer is the magnification view. It does exactly what it sounds like. It zooms way in on a small area of concern, so the radiologist can get a better look at the shape and the pattern of those little calcifications. And here's a cool insider fact for you. These are the only mammogram views taken without using a grid, which is a piece of equipment used in all the other shots to improve image clarity.
Okay, round 2. The radiologist sees a potential lesion on that top-down CC view, but it's completely vanished on the angled MLO view. How on earth do you figure out where it is in 3D space?
That's when you call for a true lateral, or ML view, which is a straight-on side view. And this is where one of my favorite little tricks comes into play.
To figure out if the lesion is on the inner or medial part of the breast, they use the saying, Muffins Rise. Medial lesions will actually appear higher up on that true lateral view, just like muffins rising in an oven. It's such a clever, low-tech way to pinpoint exactly where that lesion is.
Okay, so perfect positioning is one half of the battle. The other half? Hunting down artifacts that can ruin an otherwise great image. So, let's put on our detective hats and learn how to spot the most common culprit.
And public enemy number one for sure is blur. It can happen if the patient moves, even just from breathing, or if the compression isn't quite firm enough to hold everything still. And the danger is pretty obvious, right? Blur can make those tiny critical details just disappear into a fuzz. So how did the pros spot blur that might not be super obvious? Well, here's the expert strategy. They look at the Cooper's ligaments. These are supportive structures inside the breast, and on a sharp image, they should look like crisp, thin, white lines. If they look kind of thick or fuzzy, that's your smoking gun. It's almost certainly blur.
Okay, we've gone through checklists, weird measurements, special views, even detective work. But why? Why all this obsession with the tiny details? Why does all this meticulous work matter so much? Let's bring it all home.
It all comes down to this number, 3 to 8. What in the world could that possibly mean? Well, it's the entire reason for all of this precision.
And there it is. For every 1,000 women who get a screening mammogram, the national goal, the quality benchmark, is to find between 3 and 8 cancers. I mean, think about that. You're looking for a tiny, tiny needle in a gigantic haystack. And there's just no way you can find that needle if the picture isn't as close to perfect as humanly possible.
So, let's end on this thought. Think about it. If a mammogram is telling the story of a person's health, what crucial plot points, what tiny details are we missing if that picture isn't perfect? From the angle of a machine to the shape of a muscle, technical perfection isn't just some nice-to-have goal, it is the absolute foundation of a life-saving diagnosis. Thanks so much for joining me.